So how do we protect things? Well, we've developed these protective adjuvants over time. We use CSF drainage, left heart bypasses, I've shown you a little bit about, colorenal perfusion, and reimplantation of segmental arteries. CSF pressures, we use a fairly standard drain, and we try to drain to keep the pressure less than 15 millimeters of mercury throughout the procedure. We try not to drain more than about 20 or 30 cc's per hour. The early postoperative period, we also keep the pressure, the CSF pressure, 15 to 20 millimeters of mercury. Maximum drainage is about 25 cc's per hour, no more than 40 to 50 cc's over 4 hours. We try to remove the drain in about 24 to 48 hours. If we have a delayed paraplegia or paraparesis where we don't have a drain in, we'll go ahead and add that. And we've done some prospective randomized trials on this showing the benefit in these extensive aneurysms, and it is why this is in the guidelines. This is the Isselbacher 2022 guidelines from the American Heart and the American College of Cardiology. And as you can see here, it's a #1 recommendation for extensive thoracoabdominal aneurysms and delayed spinal cord dysfunction. It's also recommended strongly. So with regards to left heart bypass, we've done some retrospective analysis of large numbers of patients. And here in this trial from a number of years ago, we looked at 330 extent 2 thoracoabdominal aneurysms and found those whom we carried out with left heart bypass had a significantly reduced incidence of postoperative paraplegia. And you can see here it went from 13.1% down to 4.8%. Colorenal perfusion, as I mentioned, we've in the past used a crystalloid solution, lactated ringers with an addition of mannitol and prednisolone. But in recent years, we've replaced that with the custodial material. And we give this intermittently. We'll give about 300 cc's to 600 cc's initially into the kidneys, and then we'll repeat that about every 10 to 20 minutes to keep the kidneys cool. We base this on information we did with clinical trials, looking at cooling the kidneys down, where we actually had temperature probes in the kidney parenchyma itself. And we'll use, to perfuse the kidneys, we'll use anywhere from 9 French up to 14 French balloon catheters. Been a strong believer in the reattaching and direct blood supply to the spinal cord by reattaching intercostal arteries over the years. And this is how we base this. We looked at over 1,100 extent 2 thoracoabdominal aneurysms, and we had available for evaluation 1,114. And what we found was that if we reattach intercostal lumbar arteries, there was a 62% reduced risk in paraplegia. And this is the basis for which we recommend this. We've also, in years past, did a prospective randomized trial, which also for the CSF drainage, but we've never really done this for this particular entity, but we've based it on large numbers of retrospective analysis. Other risk factors for paraplegia we found were emergency repair, coronary artery disease, and chronic symptoms. And in addition to intercostal arteries reducing paraplegia, patients with heritable thoracic aortic disease, such as Marfan syndrome, have a lower incidence of paraplegia, partly because they don't have a lot of superimposed intimal atherosclerosis, so they have a fair number of intercostal and lumbar arteries available for reattachment. So over the years, we've gone from a clamp and sew technique to using these adjuvants of left heart bypass, CSF drainage, visceral and renal perfusion, in the selective use of branch grafts, as I showed you in the drawing. So we've got no single measure improves the outcomes, but there's a number of techniques that I think you have to have a sort of a broad spectrum approach to a complicated problem. We have a multidisciplinary team, and I think the surgery needs to be well planned in advance and carried out in a very meticulous fashion, particularly with regards to hemostasis. So we like to minimize ischemic results to the organs, as I've showed you, optimize spinal cord perfusion with CSF drainage, intercostal arteries, and distal bypass, minimize intraoperative bleeding with meticulous suturing for hemostasis. This is the results of 3,800 plus thoracoabdominal aneurysms. This is all comers, extent 1, 2, 3, and 4. The 30-day mortality was 5.6%. Persistent paraplegia was 2.9%. And renal failure requiring either temporary or permanent hemodialysis was a little over 8%. So I'd like to stop there and just let you know that it's an honor to have the opportunity to spend some time with you for this.
Thank you very much, sir. Thank you.